All right, good evening again, everyone. We will call the meeting to order of the Pajaro Valley Healthcare District Hospital Corporation. Rosie, will you take roll call, please?
Yes. Director Cox.
Here.
Director Pimentel.
Here.
Director Gallagher.
Here.
Director Nunez.
Here.
And Chair Friel.
Here,
We do have an amended attendance announcement. Chair Friel has requested permission to attend remotely per AB 2449, which states that a board member may participate remotely per just cause should he have a contagious illness that will keep him from attending. I'd like to make a motion that Chair Friel be able to attend remotely.
I will second that.
Moved in second. Thank you.
Great. Director Pimentel.
Yes.
Director Cox.
Yes.
Director Nunez.
Yes.
Director Gallagher.
Yes.
And Chair Friel abstaining. And Chair Friel, you have a disclosure for anyone who may be in the room with you for HD.
no, not at this time.
No one's in there with you, meeting? Under 18? Chair Friel, do you mean that no one under 18 is with you?
No, there's no one here.
I'll assist the chair from here on out, just some logistics of the meeting. We held a closed session. Is there any report out items from closed session? I believe there's none. We'll move on. Are there any agenda modifications to today's agenda from staff or board? Seeing none, we'll move on to public comments on matters not on the agenda. This time is set aside for members of the public to address the board on items that are not on today's agenda. No action or discussion shall be taken on any item presented, except that any board member may respond to statements made or questions asked, or may ask questions for clarification. All matters of administrative nature will be referred to staff. All matters related to the board will be noted in the minutes and may be scheduled for discussion at a future meeting or referred to staff for clarification and report. Any public comments? Anybody online, Rosie?
We do have 2 online attendees, but I do not see any answers.
We'll move on to comments from board members. Any comments from board members? No, I don't think so.
Happy holidays. How about that? Thanks for being here.
Yeah.
Oh, yeah. I do want to thank everyone who has worked. Katie at our last board meeting, the special session, said that she had to work throughout the holidays. So just thank you to all the Watsonville Community Hospital employees that are working throughout the holidays. Like Katie said, someone has to keep this place running. And I just appreciate all the hard work. So thank you.
Thank you.
And I'll remind our public from a public safety perspective, although we are not at a period of forecasted floods, we are at a period of high coastal water dangers. Over the next couple of days through Friday, please stay away from the oceans. These are very, very dangerous times for us. It happens every couple of months during this time of season, and it's happening right now for us. Fortunately, these same elements occurred last year, but we are also experiencing unprecedented rain. So that doesn't look to be the case, but just stay away from the coast and please spread the word. We don't need any new any new admittance into our ER over the weekend. And just echo the gratitude to all of the hospital staff that have continued to keep us functional, operational, and thriving. Thank you. No other comments. We'll move on to the consent. All items listed on the consent calendar are considered and acted upon by one motion. Members of the public may request that a board member pull an item from consent agenda for discussion prior to the start of the meeting. And if there was none, I'll ask for a motion to consider approving the consent. So moved.
I'll second that.
Thank you. We have a motion by Dr. Gallagher, a motion by Tony Nunez. Second. Rosie, would you mind?
Yes, sorry. Director Pimentel.
Yes.
Director Cox.
Yes.
Director Nunez.
Yes.
Director Gallagher.
Yes.
Chair Friel.
Yes,
That moves us to our first discussion item. It's the Medical Executive Committee's report. This is a continuation of items that heard in closed session. We have consideration of passing a motion to approve the MEC report. Are Are there any additional staff comments related to this item? The report has been included in the board packet that was sent out and published on Friday. Any comments or questions from the board members? Any public comment on this item before we consider taking action? Or is anybody, you'll bring it back to the board for action prior to passing a motion to approving the MEC report as outlined in the staff recommendation?
I'll make that motion.
I'll second.
Thank you. First by Tony Nunez, second by good friend Katie Cox.
Thank you, Director Benedetto,
Yes.
Director Fox,
Yes.
Director Nunez,
Yes.
Director Gallagher,
Yes.
Chair Fredo.
yes,
Item number 5 is the Watsonville Community Hospital Quality Report for December 2023. This is a brief receive and file, no action required. Do we have a summary from staff?
I have a presentation. Do you not have a?
Tracy's with surveyors, she's in with them still, so she's not able to join us tonight.
Okay. There's information in the board packet,
The presentation is in the back of.
so we can accept and file that, and no discussion is necessary required.
If there's any questions. Can I make a comment? Please. Yeah, sometimes the acronyms elude even me, having done this for a long time. I'd ask that the slides just have the description of what the acronym is. I had to look up HOPI. That's all. I thought it was remarkably good. No UTIs, no central line infections, all those things, quite reasonable.
Thank you for that. We will make that note. So this item requires no action. It is received and filed. We'll move on to item number 6. This is our Da Vinci lease proposal.
Thank you. This is about a year ago, we were here talking about the Da Vinci rental, and at the time that was the only available option to us because of our lack of credit history. Now that we have an established history and 12 months of payment history with Da Vinci for the rental, a lease option is available to us. So what I put before the board is an option for a 60-month lease with a fair market value buyout at the end of that lease. Summarizing it, essentially saves us $87,000, a little over $87,000 annually when compared to the current rates that we've been paying over the last year. And you can see in the back of the report, you can see an indication of the chart of volume and the decline in volume when we were still using the SI and the upticks. We've switched over to the XI and we expect that trend to continue. So we're asking the board to approve the 60-month.
Thank you. Any questions from our board members?
What's the technology time? Is five years reasonable for this piece of equipment, or is it evolving quicker than that?
There's nothing in the pipeline. However, there's a technology clause within this lease that allows us to upgrade if a new system comes out prior to the end of our lease. We can convert to that system.
Great, thank you. I move approval.
Sorry, appreciate that. Love it. Any questions from the comments from the public?
Yes,
Yeah.
matter of fact.
Yeah, thank you.
Sorry. First of all, as a former surgical technologist for 40 years, and as somebody that had several relatives that are nurses in the operating room at other hospitals, and who keeps in touch with the people that work in the operating room at this hospital, I've never been a fan of the robot. I think it's a gimmick. I think it's something that is a toy that surgeons like to play with, and they like to have the hospital pay for it. And I just wonder, when we decide to go forward with a commitment for a lease, who was consulted? Were the employees consulted? Was the staff consulted? Was it purely a financial decision? Those are questions, and that was kind of a rhetorical question on my part. The other thing is that, my understanding is that it takes a lot of cases to pay for even the rental of the robot, and I'm wondering if we're doing enough cases to do that. And the other thing that I just learned was that there's a surgeon that comes here that uses the robot. And the procedures that he performs requires an assistant. But he most often does not have an assistant. So that means that the hospital has to furnish a second tech or nurse for as an assistant. And I'm wondering about the financial responsibility for that. We're paying a nurse or a tech to do the job that the assistant's supposed to be doing. And about reimbursement, I'm absolutely positive that will not get reimbursed for the tech performance of the assistant. And also the liability. I mean, this person's doing an assistant's job, which is an argument that goes back way beyond, this, but those are just my concerns about this.
Thank you for your comments. Any questions, any response from staff? All right. Comments, questions from the board, otherwise we go back to your motion, Joe.
Move acceptance.
Thank you.
I'll second that and just also thank staff for moving this forward. I know this was something that was part of the business turnaround plan, but I think is also something that physicians have been asking for a very long time. And so I'm just happy to see this move forward. Thank you.
We have a first by Dr. Gallagher, second by Tony Nunez.
Director Rental,
Yes.
Director Cox,
Yes.
Director Nunez,
Yes.
Director Gallagher,
Yes.
Chair Freeland.
yes,
Thank you. We'll move on to item number 7 on our agenda. This is the blood bank software upgrade.
Director Rental, Dr. Brennan, you have Tracy in the room if you wanted a presentation on item 5.
I mean, I think we come back to that next month if there's something to highlight in that. I think we're good.
Sure, whatever works for you. I'm sorry, I was tied up.
Thank you for that. So item number 7 is our blood bank software upgrade.
Thank you, Marcus.
Yep.
So this is again, requesting a motion from the board to accept us moving forward with the software upgrade in our blood bank department. We're currently operating on software that's no longer supported, as well as that software utilizes PCs that are well outdated as well. So the concern is downtime issues become manual processes in the blood bank world. It's not the desirable process. So this will get us onto the latest and greatest software technology through SCC, which is soft computer. It's a system that we had prior to the current system that we have in Humanetics. It's been vetted by the laboratory staff, the laboratory lead as well, and all have given a thumbs up to the software as being something that they'd like to have and meeting the needs of the organization. The financials are detailed there as well. If you have any questions, be happy to answer them. But again, this mitigates the risk that we currently have with downtimes and the potential for challenges in the blood bank.
I do have a question. Matco, does this mean that some of the hardware gets upgraded as well?
Correct.
Okay, great.
Comments?
Any other comments from board members? Questions? Public comment? Or is anybody online? Come back to the board for action.
I'll move to approve.
And I'll second that.
Thank you, Dr. Cox. Thank you, Tony, is the second.
Thank you. Director Rental,
Yes.
Director Cox,
Yes.
Director Nunez,
Yes.
Director Gallagher,
Yes.
and Chair Freeland.
yes,
Moving on to item number 8, our 2023 Community Health Needs Assessment. This action will require a motion. So leave that as a staff for a presentation.
Yeah.
That's exciting.
So Nancy Gear gets really the bulk of the credit for spearheading this and organizing this this endeavor. But I will go through our slides in our presentation for what we have done for our community health needs assessment. So this is a new requirement for us as a newly knighted nonprofit hospital that we do a community health needs assessment, and we will continue to do this once every 3 years. If you could go to the next slide for me, Rosie. And click 2 more times so that everything in that slide comes up, I think. Thank you. So the community health needs assessment is a multidisciplinary process that goes through a survey. So we get survey data from people in the community. Many of you in this room may have been surveyed yourselves about your assessment and opinion on the needs, the healthcare needs of the community. We use a lot of data that is publicly available and that our partner PRC was able to collate for us. And those data are then aggregated, and we use the survey data to determine the top, sort of prioritize the healthcare needs in sort of a ranked order of sort of most pressing for the folks who were surveyed and based on some of our data. So if we go to the next slide, and Rosie, I'll move through these pretty quickly, these slides. We've got about 20 of them, but they're less than a minute each. So the top health priorities, you can see the top 5 that were listed here: social determinants of health, diabetes, mental health, nutrition, physical activity, and weight is number 4, and substance use. And then you can see a number of other health issues that were identified during the course of the survey and the data as well. So I'm going to go through some of the data for the top 5, because those are the ones that we will end up basing our implementation strategy plan on, which will then come back to this board in March for additional discussion and approval. So next slide, please. So on the social determinants of health, this was the one that came up the most. So you can see 100% of respondents responded that it was either a moderate or a major problem, with most people saying a major problem. And the greatest concerns were around housing, income / poverty, and the overall impact of health on those social determinants of health. So housing was a big one. So we know this one. This is clearly linked with health and with population wellness and well-being. And our hospital service area, which is an area slightly larger than the Pajaro Valley Healthcare District boundaries. It extends out a little bit north into more of Santa Cruz County. But in that service area, we outpace California and the US as a whole for percentage of households where the housing costs exceed 30% of the household income. We also exceed California and the US for population with no high school diploma. So education is another key component of this. Yes. So this one is, so unemployment rate, we are also slightly higher. We've had times when we've been a little bit lower than California, but are back to being higher. We didn't recover. This county hasn't recovered as quickly as other parts of the state have in terms of unemployment rate from the pandemic. And so we are 5% compared to lower percentages in California and the US. So item number 2 is diabetes and diabetes care. This is an interesting one. So very popular on the major problem and moderate problem by the folks who answered the survey in terms of awareness, education, access to healthy foods, access to care and services and medications for diabetes care. But if we go to the next slide, you'll see that we actually have better rates than California and the US. So this is one that comes up a lot, and I think it's an interesting perception. I heard it when I was interviewing here, and I talked to the medical staff that diabetes is a real problem here, and it is. And statistically, it's actually less of a problem here than at other places. So that's an interesting one from a strategy implementation standpoint and how we prioritize the effort that we put into this versus some of the other ones. Go to the next slide is mental health and behavioral health. So this is one, 72% of people said this was a major problem, and it's really about access, right? So if you go to the next slide, you can see access to mental health providers, number of mental health providers per 100,000 population. And we are sort of right there with California in terms of having similar access to mental health providers, and those rates are better than the rest of the US, which is good. But still clearly a challenge. Like this is not a healthy number of providers anywhere in the country. We know this based on how difficult it is to see somebody, and particularly based on how difficult it is to see somebody if you have Medicare or Medi-Cal. Lots of mental health providers, particularly in California, only take cash pay. So that's another challenge and concern. Next slide. And our age-adjusted mortality by suicide is about 30% higher than California and right on pace with the US average. And so that's something that I know that the Public Health Department looks at and talks about a lot, and the healthy people average, we're quite, we're about 10% higher than the healthy people goal for 2030. So we'd like to be able to get this number improved. Next one. So nutrition, physical activity, and weight, 63% of people said this was a major problem around awareness and how our environment and our communities are built. And again, back to nutrition. And our prevalence of obesity right around California average, so similar in Santa Cruz compared to the rest of the state. And California tends to be a little bit better than the rest of the US on rates of obesity and overweight. And that's and diabetes, as we saw before, so that's similar here. And number 5 out of 5 on the top issues was substance use, and see a pretty even split between major problem and moderate problem, but still not many people thought it was a minor problem or not a problem at all. So access to care and services, prevalence of substance use issues, awareness and education, and the stigma around it. We do have some great services available in Santa Cruz County that we don't, and that a lot of other communities don't have in this area, but it can always improve and get better. So next slide, Rosie, is the percentage of people engaging in excessive drinking was one of the key metrics that was able to be pulled out of the publicly reported data, and we are higher in Santa Cruz County than both California and the US on this one. So that's an education piece. That's something that starts in the schools, that's a partnership with schools that could address this and on from there. Next slide. And then drug overdoses. So as part of the mental and behavioral health, we have drug overdoses as a age-adjusted mortality. And this is, as we know, has been a challenge in Santa Cruz County more so than in other parts of California, but less so than in other parts of the US, where we see much higher rates. But it is still an issue. And if we saw a trend graph on this one, we would see it going up and up over the last number of years. So reversing that trend is important. So again, those top 5 health priorities, we will build some strategies around. Some of them we already have strategies around. We just need to document them as part of our community health needs assessment implementation strategy plan. And others, we will build them, or we will build those strategic plans around. We will partner with organizations in the community on what those plans are and bring those back to the board for further discussion. Next slide, I think, is the last one. So yeah, so that's that implementation strategy, and we'll bring it back in March because it's due in April. And so with the adoption of the community health needs assessment, which I just went through the high level, and you should have, did they receive the full PDF of the report?
Yeah.
100 page or 90 page or whatever it is. So that will be, once that's adopted here by the board, that will be posted on our website for to be publicly available, as it is for all nonprofit hospitals in California. Right. So I'll take questions and I'll do my best.
Questions from the board? Yes.
Dr. Gallo.
I do, I'm happy to go second or third. No. Our service area.
Yeah.
I always, well, to preface this, I think this is a really good report. We have a very short period of time. My hat's off to Nancy for doing this in the required time. My understanding is that it was shortly after we got our nonprofit status that this was put in her, on her desk with a December 31st deadline for presentation. So I think good on you all for having this be. I worry about averaging APTAS into our data, and I wonder if in the new year, there is an inexpensive way to ask the consultant to look at the data for Watsonville Freedom and the North Monterey County and see if it comes to different conclusions. I think that would be a useful thing to do if affordable or reasonably affordable.
Yeah, absolutely. I think the more we can specify data to our healthcare district boundaries, the better, for sure. When I was at a United Way presentation recently, they aggregated the whole county, and in fact, they were aggregating Watsonville with Scotts Valley specifically, because that was the way those particular data were, and that wasn't really helpful. And some of these data we're lucky to get them by county, right? They're not always available and broken down by zip code or by census tract or anything like that. There are some, and there are others that we just haven't been able to find, and so there may be ways to try to get some of those ourselves with survey data. The United Way used to do, some really good surveying of health in the area, and that could be broken down by more specific geographic areas. But yes, we'll definitely ask and continue to try to push for more of that, because that's really important. I agree. North County and South County are not the same.
Yeah, and to that point, we were told that I think it was the real cost of living at the United Way, and even there, they're saying even a zip code or a census tract is really difficult to pinpoint the exact location of like health, even in like the Pajaro Valley, Watsonville. So that's really difficult, but I think this is a really great start for us. Yep. And we have so many partners that we can work with this. I love the idea, and I think Keisha over at the United Way was thinking about, what if we bring back the CAP report? And that was something that was such a huge tool for our community. I mean, you think back the impact that the CAP report had way back in the 90s, early 2000s, where teenage pregnancies, and being able to identify that, bring in federal dollars into Watsonville, and lower the rate significantly for teenage pregnancy. So I think this is a fantastic start. I mean, this is the stuff that on Christmas morning, I love to look over as we're unwrapping presents, the 900 or however many page assessment. My question and kind of direction, Steve, is in the health. I think it was an access to healthcare. It's not one of the top 5, but there was one agency or 2 agencies that were missing. One was Santa Cruz Metro. And I know that they just redid their service lines to have more buses on the road and more consistency. I think that there's like a natural partnership between either having like a shuttle in downtown Watsonville or somewhere else in our district that only goes there and comes to Watsonville Community Hospital now with their nonprofit status of applying for federal grants and transportation grants that would fund something like that. I know that their new CEO is looking for these sort of community projects. Just a plug for my employer as well too, Community Bridges Lifeline. First Transit, there's other shuttle services that operate within Santa Cruz County that would be great for something like that, and just having a shuttle service to lower the hurdles for people to get here and to get their, their care here, their primary care provider. I think that would be great. And the Regional Transportation Agency as well too, or RTC. Yeah, they'd be a great partner to try to go in on a federal grant with this of like, hey, let's try this out for 2-3 years or however much, and just try to go find a grant to have some sort of shuttle service. Just speaking from my personal experience, my wife works with a lot of seniors in the area through the Watsonville Senior Center, and one of the tough things for them is just trying to get here because we're so far away from the center of Watsonville for a lot of people. And so like getting on a bus in the normal transit is like an hour long kind of thing to wait for it and then take the loop all the way over here. And so that'd be, I think that's one of the partners that needs to be on there. But everything else, I mean, I love, like I said, I love reading over this stuff. I think these are kind of the milestones that we can continue to plant the flag in and say, this is where we should be going forward. And these are the things that are important to our community. But like Joe said, narrowing down that data and using as many, as many avenues as we can to continue to improve this data. And I know that's something that's really important to you and your administration. So thank you. Thank you for it.
Great, thank you.
Any other comments from the board? Public comment. Rosie, anybody online?
No comment on mine.
I'll offer just a appreciation to Nancy, who isn't here. I can only imagine how much work this has been quickly, like everything we had to do quickly. Adopting a strategic plan in several months, completing our first audit in several months, adopting a budget for an entity that didn't have a budget before. Just so much things we're having to build from scratch. And I'm appreciate all the staff's efforts, and this is one of them, but it isn't just checking a box. It's actually thinking about how does this fit within our strategic plan? How does this move us forward as a community? So I'm just grateful for the team that we have, and please pass my appreciation and our board's appreciation to all the staff behind the scenes who touched this. I understand this is, that's a minimum standard that's pretty generic, and we have more ambitious stuff in our own strategic plan, but it's still impressive, the quality of this report and how well thoughtful it was with the outreach and so thank you for all that.
Absolutely.
So that being said, we will require a motion to consenting to the Par Valley Healthcare District Hospital Corporation adopting the 2023 Community Health Needs Assessment. Do we have such a motion? Let me move that motion.
I'll make that motion.
Well,
You go first.
John, we'll put you in second.
That's
Because I
fine,
heard
I'll
your voice
second the
first.
motion.
Yeah.
Yes,
So Dr. Cox and seconded by former chair. John.
Director Pinto?
Yes.
Director Cox?
Yes.
Director Nunez?
Yes.
Director Gallagher?
Yes.
Chair Friel?
yes,
Thank you. We move on to item 9, which is just an oral report of our chief executive officer.
Yeah, thank you. So report number 2, I am going to continue to organize my thoughts and my notes and reports by our strategic initiatives. So I'm going to keep that as a theme. So I'll start at the top of those strategic initiatives with community health and advocacy. We have had the opportunity to present updates about the hospital to a number of community organizations, including the South County Leadership Group and the South County Triage Group, as well as some local Rotary groups, which has been great. We also had Holiday Hope, thanks to some of the folks in this room who did an amazing job working with staff and physicians who raised over $12,000 for farm worker families. And we had a wonderful event with Santa on Saturday, December 9th. On the provider recruitment front, we have been making progress towards additional intensivist coverage for critical care patients. And we have interviewed a surgical specialist from the Sacramento area who has interest in potentially joining our clinic. And we plan to have that particular surgeon out for a visit in a little over a month. So we're looking forward to that. Hopefully we can get some progress and success there. On clinical quality and patient experience in January, we're going to begin our assessment with Beta Heart. Beta Heart is an organization that we already partner with for our liability insurance, and they will be helping us train leaders and providers and staff on, among other things, adjust culture and how we look at human errors and how we look at process before people, and looking at making sure that our processes are safe and how we do that and what that culture looks like. So Allison, Tracy, some combination thereof will bring more to the board on that in the future in the coming months. On talent and culture, as you know, we were able to ratify the California Nurses Association contract, so that was a great step forward. We conducted town hall meetings for staff, 3 of them to be exact, on Monday, December 11th, and had lots of good discussion about the update of what's going on with the hospital and what our future looks like and future measures of success. We had a successful holiday soiree where over 270 people were in attendance at the Coconut Grove. That was a wonderful celebration to get to see everybody. We held a leadership team, so that's all our managers, directors, and above working session on looking at operational objectives for 2024. So in early 2024, I'll bring the board a working version of our hospital dashboard, which will have our key measures of success underneath each of the strategic priorities and strategic objectives. And we'll talk a little bit about how we'll track those metrics going forward so that everybody, all our key stakeholders are informed throughout the year of what we're working on and what's important to us and how we're doing. As you know, our CNO is Sherry is an interim, has been for some time now. And we have two solid candidates that we're working on scheduling on-site panel interviews for shortly after the new year. So we're looking forward to that. Allison and I are working on leadership development plans for the leadership group, the management director group for 2024. So we'll have more to come on that. Clinical services and access. Just one item, we had a nice meet and greet and tour with the new regional VP for Kaiser Permanente. So they've had some leadership turnover there. And so as they indicate that they're looking to continue to expand services and membership southward. So they're interested in further partnership with Watsonville Community Hospital for their members. So more to come on that, but that's those are good conversations. I'm sure we'll have more strategic conversations in the future. And the 6th pillar is financially sustainable services, and I'm going to defer that one to Julie for when she does the finance presentation and the budget presentation. And I'll stop there and take any questions.
Hard not to have a sneak preview of effectively balanced budget, but I appreciate holding that line, keeping our interest. Question from board members. Yes, sorry, Joe.
Stephen, are you willing to comment about the specialty surgeon from Sacramento? What specialty or subspecialty, or not at this time?
I prefer not to at this time, if that's okay.
Sure. A comment from years past, there used to be a GYN oncology surgeon named Sam Ballard, long retired. He'd come over from San Jose or Palo Alto once a month. It was a focus of GYN surgery. The local surgeons got to work with him as an assistant, learned a lot from him. The patients got to stay here, have their care done. And it was a really, really wonderful thing. Just the point of information, there may be some equivalent younger person within the area for GYN oncology.
Yeah, we have a list of, and I was emailing with one of our physician leaders today, just the list of possible services that if we had better physician coverage, we could reduce the number of patients that we're transferring out for care, because we don't have that coverage, we don't have that specialist at all, or we don't have that specialist, being able to cover the emergency department on a regular basis. And so that's certainly one on the list, which is something we could certainly do here safely if we had the right providers.
a quick comment. I thought your bow tie was great at the holiday soiree. And I hope that your dog didn't get skunked too bad.
Oh,
Um,
man,
yeah.
yeah, thank you.
So.
Yeah. Right, right in the chest. It's a long night of bats. Thank you for your sympathy.
I just comment on the delivery of this. It was very nice in reminding us the elements of our strategic plan.
Yeah.
And having presented that way, so I appreciate that. And that's a very helpful way of listening to this report. Thank you for that. You know, I can get in the weeds of certain topics. So when you talk about your liability insurance and beta heart, like I got all excited about that. But I was getting the weeds of preventative issues,
We will,
especially as we get into.
we'll bring you some more weeds.
Yeah, well, maybe outside, you know, public might get bored and turn their TVs off. They sort of,
Yeah,
yeah.
some of them are good. Good weeds, yeah.
But I appreciate taking that next level, not just about how to prevent things and how to provide better patient care to prevent things, but also thinking about how we have our processes and
Yeah.
adjust methodology about that's taken it to the next level. So
Yeah.
thank you for embracing that and bringing that level of focus. So appreciate that.
And developing our leaders around that.
Yeah.
That too.
This is just a report out, no action required. Any further comments to our board? None, we'll move on to item 10. You've got the teaser about our financial report, and budget update.
Okay, actually, we'll do the financial report first, because I have a whole separate presentation on the budget. Go to the first slide. So I wanted, since last month, we did not bring a financial report to the board because we were kind of sorting through October with the results of putting in audit adjustments. I wanted to give you a 3-month trend, just to kind of bring you back to September, so you can see the 3 months in one, and also, you know, to let you know that what we had, we ended up having to restate what we had presented in September after we posted some of the audit adjustments. So, generally what you see here, and the biggest highlight is that in September, we are now under our restated financials showing a negative EBITDA of 8.3 million. That's about $5 million higher than what we had presented before. It's all related to how we valued the accounts receivable and some of the movement that came as a result of the audit, which was really on our 4-month period of 2022. The biggest reason I want to highlight that for you is because then you can see the movement in October and November, which is we got better in October because we had some positive adjustments, again, one time related to the audit, not truly part of operations. And then in November, which is primarily all operations, we're back at the $8.3 million negative EBITDA. As I go through the next slides, it'll probably become a little more clear where things are. So let's go to the next slide. So just a quick look at October. I'm really only going to spend one slide at October and then get into the year-to-date stuff. But, you know, on a month-to-date basis, October volumes were down. We've really been down through the summer and into the fall. We did have a pickup, as I mentioned, because we had to, one of the audit adjustments was about how we record the revenue from the Packard loan. We got the cash back in November of 2022, but as you make payments, which we made a payment in March of this year, you record the revenue as other operating revenue. So this is a non-cash pickup for the month of October. You won't see that in November. So keep that in mind. The 1.7 is positive. That also played out a little bit in the expenses on how we record for the quality assurance fee payments that we make to the state, and that we adjusted our process around that as a result of the audit. Next slide. So then, kind of now getting into November, comparing ourselves to the budget as well. We lose those kind of one-time, offsets and looking at how we're doing from just more on an operational basis. We continue to, have lower volumes, so we did not produce as much net revenue due to our lower volumes. We, have been managing expenses pretty well, but we don't, shave off as many expenses as we aren't bringing in through the net revenue piece. We did have some higher expenses in supplies, some higher drug costs, higher implants, and the good news around the implants is we did have higher surgery volumes. I'll show you a surgery slide or a volume slide in a few slides. And then we had some higher costs in the lab. So the main thing here is we're sitting at a year-to-date EBITDA loss of 8.3 million. We do think that there's some one-time entries in December that are gonna help soften that, but we might also have, sometimes you have them going both ways in that last month of the year, where we take an extra critical eye on trying to make sure we've got 2023 items booked in 23. Number one, we don't want to carry them forward into 24 when they're not budgeted. Number two, we are going to have the auditors back in-house by February, doing this all over again for a full year, and hopefully, not having them find something that we should have booked to 23. So you will see when I get to the budget later that I project a more favorable year-end EBITDA. Might be a little bit aggressive, but my main goal is to land somewhere in this, $7 to $8 million range, 9 at the worst, versus hopefully not worse than that. Next slide. So here's a look at the volumes. I only listed the November, but they were pretty consistent between October and November. The only thing that was different was we did have higher delivery volume in October, and we were kind of low for November, even as you compare to November of last year when we were at 70. This year, just 54 in November. The bright spot here is probably the inpatient surgeries. We had 62 in November. We had also had 62 in October. And so that was, as you can see, up from the 44 that we were at last year. And, case mix is kind of around where it normally averages, 1.4 to 1.5, a little bit higher in October. Next slide. On the outpatient side, kind of the same story. We've, continued to be pretty strong in the emergency room, down a little bit from, definitely down from what we budgeted, but even down a little bit from the prior month. The non-ER volume is down, and it's primarily, we see it in the radiology area between some staffing issues that we've had, where we get short-staffed at certain times. And then also we've had equipment that can be up and down over the course of a few days. And so that has hit our radiology services. The outpatient surgeries were very strong in November. Now we had originally budgeted that the cath lab would be open by now, so it's not open, which is why we're not meeting budget. But we are very strong for the month, and we did see increased robot volume in the last few months, but specifically in November, to the point you made, Butch, just about is it paying for the cost of the lease. Earlier in the year, I had the same concern you had, but we have seen the uptick in volume and the increased interest by our physicians, and so we are starting to see many more robot surgeries. Next slide. I hadn't brought payer mix to you for a while, so I wanted to bring back payer mix. The gold bar in the middle is our managed Medi-Cal, which is almost all the Central California Alliance for Health. Sitting at just under 42% of our admissions. The commercial, we've done better in the last half of the year, even though the last couple months are, got really nice up in, the July, August timeframe, kind of probably more when the summer vacations and kind of the seasonality of more people in the area. But, sitting about 14% in November. And seeing a little bit of reduction on the Medicare side. Everything else is pretty even month over month. Next slide. On the outpatient side, it's been really pretty consistent all year long. We've got about 43% with the Alliance, about 24% with commercial. So we have seen a little bit of uptick in the commercial that has stayed into the fall months. Slide. That's it for the financial report. Any questions?
Probably, but go ahead. So I'll just share that, as the board knows, the finance committee meets monthly and reviews this information in a lot more detail, and a little more time. That doesn't preclude you from, this is the right time to ask your questions. I just want to let you know, some of the stuff is in the weeds, but we had a lot of fun going in the weeds, so questions from board members.
Probably more so for the budget presentation, but just the decline in volume, I guess projecting that forward into 2024, and then any like national statewide trends or anything like that that we're looking into, why that is. I know that even, social service providers are also seeing a decline in volume, people, using their services as well too. And I don't know if that has to do with some of the social determinants of health, people leaving the area, and fewer people, especially people that we serve who are on Medi-Cal and other, government funded insurance plans leaving the area. I just don't know if we're looking at those trends and if we've identified any of those things.
Well, not spending a lot of time looking at the industry trends, but a couple of things that have happened recently. The whole Medi-Cal redetermination process was on pause for a long period of time, and over the summerish timeframe is when all that redetermination, and the Alliance had estimated about a 17 or 18% decline in enrollment, and they were seeing that, or eligible, I should say eligible folks. So that's, probably a fairly significant driver for us, just since we see so much Alliance patients. Other than that, I think generally access to care, access to your PCPs and things. Not sure how inflation and just the cost of services and the cost of other things impacts people's choice about the cost of services that they're going, maybe the elective services. But we've been, to be quite honest, we've been pretty heads down, just focused on getting our arms around our own data to try to put together a detailed department level budget for the first time in forever.
Yeah.
I look forward to giving you that report next.
Definitely.
In terms of the monies that come and go that are either from the audit or from balance of payments, I have a hard time sifting those out to then look at the operational finances. Can you just give me a sense of your impression of our operational finances? I didn't miss the fact that volumes are down, but how do you think that part of it's going?
Yeah. Well, they always say that volume, kind of covers all sins. And I have to say, just putting this in perspective with places I've worked in the past, I have been pretty impressed with the team here as to how well they try to adapt to lower volumes without the CFO and finance team running around, beating them up about productivity every 2 weeks, which we haven't done because we haven't had the tools yet to do it. We have developed the tools for 24. So, the expenses tend to be fairly consistent month over month, and usually the month over month changes are pretty explainable, either with like this month it was some stuff around supplies and higher drugs. sometimes it's around a major purchase service payment, like when we have the Chartist payments. Or it can be around, some repairs and maintenance type work. But when you look at like salaries, they're pretty, and I look at those obviously every 2 weeks because I'm managing cash on a daily basis. So I pretty much project out, what is going to be next payroll. And then when it comes through, I'm like, oh, about where I expected it. So I think our expenses are pretty consistent. The problem that we don't have the volume means we have to look for every bit of belt tightening that we can do. And so you will see when we talk about the budget, some of the productivity improvements and premium pay improvements that we're, going to embark on in 24. But I think, when you do kind of sort out the kind of one-time audit adjustments and weird things, I think we're doing pretty well. The problem is we still have more expenses than we do collections. And so we aren't going to get ourselves out of this operating in a loss and being able to have money for capital until we find some other opportunities, either to grow the volumes, well, it's both growing volumes and controlling expenses even tighter.
Thank you.
Any other questions from the board? Any questions from the public? Anybody online?
No questions online.
Always makes me sad as a finance guy to have a question. I'm good with that.
Like you said, we had lots of fun yesterday.
We did have a lot. So this is receive and file, no action required. Thank you for your incredible work. I'm just continuing to be impressed with how the quality of the information we're getting, it gets better and better every month. I appreciate that. I appreciate the continuous improvement. Moving on to item number 11. This is our Colorado Healthcare District Hospital Corporation 2024 budget for consideration of approval.
Excellent. All right, well. I would first, just as we start this, I would like to, publicly thank my team. I've got Chad and Jessica here. We sit on weekly, if not sometimes multiple meetings per week talking budget. Chad and I had the pleasure of spending Friday night here till about 9 o'clock working on this budget. So thank you to my team, and please understand they are a big part of what's behind all these numbers you're gonna see. So, to the top. Somebody said this earlier, and I just kind of wanted to reiterate, I think it was you, Marcus. This budget cycle represents a lot of first times. Kind of the first time that there's been a consolidated operating budget at the department level. It's not perfect. It's not even always pretty, but it's there. And that was something I feel really good about because it was something I promised last year at this time when we were presenting a budget that at a very high level. We are going to be training our directors and managers because they're anxious for this budget and we want them to feel comfortable with it, and also to know that this is a learning year. There will be things that were missed or kind of out of categories, but this is their first time to have a budget that they kind of call their own and manage to. We developed labor standards for the first time. That's how we measure productivity on kind of hours per unit of service. And we are implementing our first charge master increase, and that is included in this budget and being implemented this week as we speak for a January 1st implementation. We do show significant improvement, 22 to 23, and this budget shows a significant improvement from 23 to 24. You will certainly note that this is operating budget only. There's no capital expenditures budgeted at this point because we aren't at the point where we're raising the cash yet to budget for capital. We have to be bringing in cash in order to do that. And so, and I know you already know this, we haven't forgotten about capital. We have a nice healthy wish list of about $15 million worth of capital. All right, next slide. So I'm gonna give you the consolidated budget in pieces, but part of your packet is a one-page view that gives you the whole snapshot look here. On the revenue side, just to show you, we are budgeting $149 million in net operating revenue, as opposed to kind of projecting to end around $136 million this year. The overall collectible patient revenue, which means after all the deductions, after our provisions for bad debt, is still about 13% collectible. We are being conservative here. We have been all over the map and back trying to value AR and figure out what we really think is the collectible percentage. That's a lot of moving parts and pieces. So we tried not to be, sometimes when you look under the covers, it feels ambitious, but when I look at 13%, I say, I think that's still within reach. And that of course includes block payments and dish payments that we get, as well as our payments from our payers. And we do include our CDM strategic increase. And what that means is it's an 8% increase, but it's not 8% across the board. It's been strategically chosen in charges that are sensitive to higher reimbursement. Next slide. On the expense side, we are budgeting $149 million operating expense, $149.5 million, as opposed to projecting to end the year at about 143.6. So we are budgeting a small EBITDA loss for the year. And then what that really equates to after you factor in the MPT lease and insurance and depreciation expense is about a $6 million net loss. One of the things that doesn't show on this slide, but does show on this piece of paper, here you see going from projecting about 13 million this year to 6 million next year. Take a look at this piece of paper, and for the 2022, I have to asterisk it because I took out the $15 million worth of cash that was just abused by the project to keep things going during the bankruptcy year. And I took out that audit adjustment for extraordinary income because it was not a cash transaction. It was just cleaning up the balance sheet losses from the seller. So without those things in here, we lost $39 million in 22 as opposed to 13 million this year. Pretty significant improvement. Next slide. So I want to take you through kind of all the major components here and highlight some of the things. Net revenue, we've already talked about, it's a $13 million increase in net revenue. We are budgeting some improvement in bad debt, mainly because we are going to have a bad debt vendor. A bad debt vendor follows your early out or your self-pay vendor. Self-pay vendors work the accounts for about 150 days. They try to make contact with patients, put them on payment plans, do whatever they can. When they can't get a hold or there's no more work that they can do, they only get like 150 days. We say, if you haven't done it by then, you don't get any more chances, give it back to us. We haven't had a bad debt vendor for the past year or longer, even before I got here. So this is new for us, but this will put it in another vendor's hand to do some more work with. It also enables us to, if the vendors, once they work counts, they can return accounts to us, and Medicare accounts that have any bad debt component to them that isn't collected, we can write off on our cost reports and get like 65% of that bad debt amount. But you can only do that if you have treated all payers the same. So going to the bad debt vendor also just opens up an opportunity for us to go after some cost report dollars that we haven't been able to pursue. So that's why we felt like, this is not a significant change, because we're really, our bad debt as a percent net revenue is only about 2.1 or 2.3% now. I mentioned the charge increase. Really, the quaff and dish projections for the year are relatively flat. Quaff 8 was delayed in being approved. Really hit us more from the cash in perspective this year, because we're expecting if quaff 8 had been approved earlier in the year, that we would have gotten some quaff payments in December. It has just recently, like as of last week, been approved. We haven't gotten the schedules of the payments, but our vendor that we work with thinks that we will see a quaff payment in January, the one that should have come in December. So in my cash forecasting, I kind of put it out towards the end of January. Last year we got some provider relief funding at the very beginning of like January. It's like weren't expecting it. It came in. We don't believe there's any more out there to be had, so we did not re-budget for that. But we do budget for another Packard loan, recognition of revenue, much like I talked about with the audit results. It's about $1.9 million that we're gonna make payments in March of 2024. So we will recognize the revenue on the income statement. Next slide. Taking a look at salaries and benefits, going from about 97 million to 102 million, ups and downs. You know, salaries is the one that always increases kind of the fastest when you start to bake in some merit increases, some of the MOUs for the union, their increases, some are already you know, the contracts are in place, so those are kind of automatic. And then, you know, we try to make sure that we're able to do something for the non-exempts, or the non-represented. So we have some budgeted there. We are have slight increases to volume. To your point, it's increases to the volume we've seen this year, not to what we had budgeted in the prior year. And so that has some extra dollars, which it also includes cath lab staff, cath lab director. We are budgeting a placeholder for staff education. I see my educator over there who's happy to see that we're budgeting some dollars in her neck of the woods. And then, as I mentioned, we are implementing some productivity improvements. I'm going to talk about that a little bit more on the FTE side. A little bit of premium pay reduction, and we, towards the last half of the year, we recognized some agency costs going down because the hourly rates went down in the fall, and so we're always hopeful that we're going to have less agency and more FTEs, but you know, again, being somewhat conservative here. On the benefits side, you know, the hardest thing about benefits is when you work with the brokers and you look at the experience of being self-insured, it's like, you know, I'll budget another 20% increase. So it's pretty big on the health insurance side. You can see a $2 million increase. You know, when you have additional volume, you end up with additional taxes, you know, additional salary dollars, additional taxes. And then we have some pension accruals that we need to start budgeting for, because we learned through the process of some of the work that we've done in the 401(k) plans and all the transition from cash benefit, that we had some missed accruals that we want to make sure we're budgeting for and planning for. And, you know, the best news was probably on the decreases side. Some of the work that Allison did with the contract negotiations in getting out the bit about nobody has to pay their co-pays, at least in the nurses contract, we were able to do some work around that. And then significant workers' comp reduction, because there's been really great work done by the HR team on the workers' comp cases. Next slide. So here's a little look at FTEs. This year, current state, we're sitting at about 523 FTEs from the hospital side, about 13 more on the clinic support side, and about 2.4% of our productive hours in overtime and double time. When we look at the 24, it's not that much difference, a little bit higher in the FTE count, both from the little bit of volume that we've projected and the cath lab. Clinic support is, flat, and, quite honestly, I'll say it now because I'll probably forget to say it later. The clinic is budgeted right now is just kind of a flat year over year. We really put all of our focus into the hospital. And we will continue to develop our reporting and our abilities to drill into the clinic in 24. So we had almost, 547 FTEs before productivity improvements. Then we I call it nibbling around the edges. We didn't just drastically slash any department, say you gotta, cut FTEs. It was a very thoughtful and just nibbling around the edges. We really want our leaders to feel comfortable in their first year of true accountability to labor standards, to think that this is something manageable and something achievable, and we'll continue to work with them as we need to, those places where we need to tighten the belt, especially if volumes don't materialize as we budgeted. So we have overall, it results in an 11 FTE reduction, but no department has taken any significant hit, and the smaller departments, they basically, you got one FTE, what am I gonna do, make 0.95 FTE? It's probably not gonna materialize. And then we are working towards a 2% overtime double time. You try to just bring it down as well as we can. And here, this is just pure overtime, double time. A lot of times it's kind of those incremental 15, 20 minutes. It's not your callback pay or some of your expensive pay. I think some of this we will also get just in some of the union, the things that came out of the CNA negotiations and how they were doing double time in cases that didn't necessarily warrant double time pay. All right, next slide. On professional fees, so these are our mostly our on-call payments with the various physicians and various specialties. Not expecting any decreases. We have put some money aside as we're continuing to develop this intensivist coverage, looking at getting our anesthesia coverage a little bit more solidified so that we can feel confident that we can run through rooms pretty much all the time. We just added a little bit more in GI coverage because we really only had Dr. B for half a year, and so we wanted to make sure there was coverage for that. We put a little bit of money in for any contracts that might be coming due that have an inflationary component to them. Next slide. On the supply side, this is relatively flat because for everything that we're gonna increase by having the cath lab or having kind of volume and inflation increases, we're hoping to offset through our inventory cleanup. Almost every department that's been working with our supply chain manager has identified that there's probably some par opportunity within their area. We have now implemented the Vizient contract. That was part of the 2023 initiatives that took longer to get implemented, and so we've booked some of the proposed savings, and we're trying to make sure that those are all real. And then we're moving forward. Jennifer's been working hard on the 340B for the outpatient pharmacy drugs and looking at about a $79,000 savings there. On the purchase services, also a fairly flat year over year change because we're continuing to whittle away, what used to be transition expenses out of the bankruptcy. I mean, every so often a little bit comes through, but pretty much now everything we're like, that's just the cost of doing business. These legal fees aren't necessarily related to the transition anymore, they're just our legal fees. The strategic planning, we are, we paid our large amount last year to Charters for the strategic plan. That's not going to need to be done again this year. And then, as the team was pouring through some of the accounts payable and trends, looking for some one-time things that aren't gonna materialize again this year. Now, as you can see on the increase side, we always find a few new things to put in there. So we have a few consulting fees, including things like the bond consultant. Next slide. And we are gonna have a marketing budget for the first time in a long time. Nancy's very happy about that. Quickly, utilities is pretty much nothing other than we have that contract now in place, so we saved some of the high dollars we paid this year. It's nothing really to say in repairs and maintenance. The only increases to the rents and leases is around cath lab, the blood bank software, and a little bit at one of our facilities over there. And insurance, we have some savings on the insurance side. Next slide. And then other is pretty much flat year over year as well. And then our stuff below the line, the bulk of it really deals with the MPT. And now we record the lease payments and the insurance payments. And we already started recognizing earlier this year that the insurance payment went up like $50,000 a month. Next slide. Really quickly, to the point about volumes, and sometimes I think graphs speak a lot easier than a bunch of numbers and words on the page. You can see what 21 and 22, much higher admissions, up over 4,000, only projecting about 3,500 this year. And the whole bulk of the 24 up to 36, 39 is almost all cath lab admissions. There's a slight bit of other, but it's primarily cath lab. Next slide. Here's what the average daily census has done over the years, and it gets slightly lower in 24 because when we started projecting volumes and days and everything, we had some pretty significant, some high length of stay cases earlier in the year. And so we weren't planning for those to necessarily repeat. And that's why you see 24 being slightly less than 23. Next slide. ED visits, we've got a 1% growth that has kind of continued to grow year over year. But at the same time, we've left the percent of ED visits that turn into admissions flat because there's been a lot of work by Ione and the case management team working with the physicians in the ER group on appropriate admissions, when to admit to inpatient versus observation, the whole medical necessity piece. So I feel, pretty confident that we'll probably stay fairly flat, the admission percentage. On the outpatient visit side, 2% growth in the non-ER visits. We have, even though it's kind of stagnated a little bit in the last month or so, mainly due to challenges. We do have the volume, and sometimes, we even know that when we're having those challenges, we have kind of the pent-up demand for those services. Also, bringing in a new service line like the cath lab generates additional lab tests or additional others needs. Next slide. And then here's what surgery visits do. It's about a 2.4% growth on the inpatient side, 5% on the outpatient. We did go kind of modality by modality, and some are up 2% or 4%. Nothing up, I don't think anything up over 5%, but then the whole infusion of new cath lab service generates the jump you see. The orange is the outpatients, about 1,400 outpatient, and 886 is the inpatient projection for the year. Next slide. So this slide here is basically what you have on your one-page summary showing that we're asking for a negative $365, almost $366,000 EBITDA budget, $6 million net loss budget, and we'll go to the final slide. This is just to request that we pass a resolution to approve the 2024 budget. I show both the hospital corp and the district on the same slide, same resolution, knowing that we will come back to this topic when we hit the district board meeting. And with that, I'll take any questions.
Questions from our board?
Truly, the missions for 21 were pretty robust and it looks dramatic drop off. How much of 21 was COVID, or do you have a sense?
You know, I honestly don't have a sense, not being here and not having really had to spend the time looking back at 21.
Okay, thanks anyway.
Questions from the public? Any questions from online, Bruce, or comments?
We double check. No questions online.
Before we take action, I just want to reflect. I got really excited at our last meeting when, looking backwards, we had effectively solved 80% of our projected deficit in 1 year. And this operating budget for the hospital, Julie, I know this will rub you wrong. We're balanced people. I mean, I know we're balanced. I mean, I know you can tell me there's a 0.002% that's not fully funded, but we're at 99.98% funded in 14 months since taking over operations of this hospital, September 2022. So this isn't this board. I mean, we've been setting expectations and high bar to reach, but it's the staff and it's the community and it's the staff who are present here who work diligently together to try to figure out how to make this happen. And I want to scream from the top of the mountain, like how big of a deal this is. But I know we're going to have a lot of that opportunities and, you know, putting information out to the public, to our op-eds. This is a historic, monumental, national achievement here done in Watsonville and for this hospital. And I appreciate the work and I have high confidence in the numbers. I know that there's stretch goals in here. I know that, and we'll have to keep revising this and, you know, getting our month-to-day actuals. But this is an incredible moment for this board and for our community to realize that what they were promised during the bankruptcy and when fundraising was happening to raise $65 million, $64 million, $33 million from the state, that we had a big objective to deliver and make this hospital operation sustainable, and this budget does that. Again, September 2022, this board met for the first time as the hospital board, and you know, here we are, you know, a year and 4 or 5 months later, adopting a balanced budget for next year. I'm just lost for words, but just overwhelmed with pride of what this has all done. So I just wanted to make that comment. Damn, I want to shout for the mountaintop, but you know, we'll save that for time without elongating this meeting unnecessarily. So
I do have a quick question. It's just about, this will, I'm assuming be a living document. It'll come back for revisions. Do we have like a regular time of like quarterly, biannually, or?
There's no planned revisions. This will be the budget.
Okay.
And then we will report and explain any significant variances. We will be able to explain those at a better level than this year we've pretty much looked at things month over month. Now we've got that department level budget. We've got some tools that Chad and the team have been developing to kind of drill into more detail. So when we have a budget variance, we will hopefully be doing a better job explaining that budget variance. The next steps for us really are, you know, with an approved budget, we're gonna load it into the general ledger at the
Mhm.
department level, so there's a bunch of work that has to go into spreading that by month, spreading it by department, spreading it by account. There's, some of that work's already kind of building under the covers, but, you know, the CFO who comes in at the end and says, no, I don't like that number, change it to this, and figure out how to roll it back down. I'm going on vacation. Chad's gonna be working on that piece. So, yeah, this is it's not going to change.
Okay.
The budget will be-
Because I would just love if we found an extra, even like $10,000-$20,000 for Nancy in that marketing department.
She's getting 100,000.
I saw 80.
Well, it's 80 and.
It's 80 plus 20.
It's
plus
80,
20.
20 was in supplies and 80 was in purchase services.
Okay,
So she's got.
So you got it.
I got it. There you go.
You're
I
welcome.
just, the X multiplier of what a good marketing strategy and plan is for a hospital, especially one that, like Marcus says, has an incredible story. I think it's just, it's a big piece to this, and I just appreciate your work and allowing Nancy to go cook a little bit, as the kids say. This is gonna be great. Thank you.
She's a very good cook with the minimal ingredients.
And as we'll talk about in our district board, in consideration of adding a member to our foundation, that foundation is an asset
Yeah.
to bring us some extra capacity and horsepower to really fire up that kitchen.
Yeah.
So before taking a motion, my last comment is, again, in gratitude and in the spirit of, you know, we're gonna do this together, just recognizing that in 2017, something bad happened in this community and bad to this hospital. And that the staff persevered through those idiots, those former operators who, you know, took over this business, flipped it, sold the land out from underneath the community. And we're not that land being owned by us. We have to get that land back in our control. And that's what's effectively creating our overall district deficit that we have when we look at our district board budget. The hospital's balanced, but when we factor in that we don't own the land, we still have a shortfall, and it's really important that we do everything we can to get that land back and these buildings back under local control. So I can't wait to get there and solve that last little nugget and provide us the funding that we need for facilities and capital that isn't, as he's pointed out, isn't in this budget. We're not growing facilities, we are not growing capital. This is not a growth budget, but it is a sustaining budget that is focused on keeping our staff here, keeping them happy, keeping them ecstatic with continuing the services that they serve for our community. So thank you all. Please give my whole appreciation to, well, Julie, I'm telling you now, that Chad, Jessica, Chad, Grace, you know, the whole team and all the managers that came together for all this. Thank you. Motion
Yeah, I'll make the motion to approve.
or pass the resolution.
That's a
Staff's recommendation. Thank you, Tony. Thank you, Joe. You have a first and second?
Director Penfold,
Yes.
Director Cox,
Yeah,
Director Nunez,
Yes.
Director Gallagher,
Yes.
Chair Friel.
I saw his lips move.
Yeah, I said yes. I was muted, but it's a yes.
Thank you.
All right, we want to adjourn.
meeting adjourned.